Michael, in patients with low ejection fraction, heart failure and low ejection fraction, there is a mitral regurgitation, but is this mitral regurgitation meaningful to think on repairing?
So it should be a significant volume overload, because that is the true problem there. And unloading the heart is finally the efficacy. So from transthoracic echo, it might be underestimated, so a transesophageal echo might be necessary. And then, of course, there should be it should be technically feasible to do it. And then you can solve beyond guideline-directed medication the direct mechanical overloading of the heart. And that appears to be important.
We are going to ask our colleagues to watch on the session. During the session, several times you said M-TEER is indicated in that patient. Can you tell us in few words what are really the best indications?
The best indications is, of course, technical feasibility, significant loading of the ventricle, and then, of course, guideline-directed medication in the stable patients in order to reduce the complications, peri-procedural complications. And then, of course, there is discussions about the criteria where the point is beyond improving the patient. So that is a tricky question. And so the majority of patients will require it, because when there is an improvement of MI, there is a better implementation of guideline-directed medications, and the patient will benefit in the long run. So that is a very tricky point. So so-called co-op criteria should be definitely looked at, but it's very difficult to exclude a patient from that criteria.
Thank you, Michael. And if you'd like to know more about this beautiful session, you just connect to IHF.